This is my honor to give the first talk. I hesitate to call myself as a medical mycology. I just the people, I the physician, to aware and recognize how important of the role of medical mycology. So I'm happy many of you are medical mycology in this room. This is my disclosure. You know, a physician in Taiwan is multifunction. We conduct clinical service, we teach students, we also do a serious research. While I will go through several issues. Last year, in Nature Microbiology, editorial gave a very strong statement. The title is Stop Neglecting Fungi. He mentioned that fungal pathogens are virtually ignored by the press, the public, and the funding body, despite posing a significant threat to public health, food biosecurity, and biodiversity. Indeed, in comparison to the threat from drug-resistant bacterial infection or viral outbreak, disease caused by fungi, fungal drug resistance, and the development of new antifungal therapeutics get little coverage. Yet in this case, no news is certainly not good news. You know why? Just because the huge gap between the issue and our capability, and the capacity to identify the fungal pathogen, to identify the invasive fungal disease or others, and the disparity relative to their other infectious disease agent unjustified. So the first question, this question is raised during this ISHAM annual meeting by WHO Antimicrobial Resistance Secretariat. Has WHA ever addressed fungal infection? Do you know the answer? Yes or no? No. Yes. Okay. Yes, the answer yes. WHA in 1975, they ever request Director General to provide assistance within the organization program to epidemiological study on superficial and deep mycotic infection, and to provide member states with appropriate technical advice on their control, and request the Director General to report to the WHA on the public health importance of mycotic disease in WHO member states in 1975. The next year, they did report, but noting with appreciation the contribution of government in reporting disease in their respective country, realizing the important place, in spite of the scarcity of data, it points out the key issue. WHO representative emphasized that they are not neglect this issue just because limited data to support the importance of fungal infection. So they recommend that member states build up specialized expertise within their health service to enable an adequate assessment to be made of the prevalence and incidence of mycotic disease and subsequent of their public health importance. 40 years later, mycetoma included in WHO agenda. The next year, chromoblastomycosis including WHO agenda. And this year, WHO organized a meeting on global surveillance of antimicrobial resistant invasive Candida infection. Class was launched 2 years ago, but this year, they include the global surveillance of invasive Candida infection as well. So WHO did pay attention to this issue. But are you aware that how the disease burden, how important? Regarding the number, do you know how many people suffer from this disease? How many of them die annually? And how about compared to malaria and the tuberculosis? We are very familiar in public health as well in medical care. Do you have any idea? Gavi, they launched this website and encouraged many people from different countries to pay attention to establish epidemiology data. They estimate that over 300 million people suffer from serious fungal disease. Totally, more than 1.6 million died annually, which is more than malaria and similar to tuberculosis death toll. There are estimated more than 1.5 million fungal species, of which 300 are known to be pathogenic to human. Infection, we all familiar with. Infection primarily occur in immunocompromised patients. However, infection of otherwise healthy people are on the rise for unknown reason. In addition, global warming is inducing rapid forward movement of cross-fungal pathogen and might also increase the prevalence of fungal disease in humans, as well as fungi adapt to survive in warmer temperature. So this is very important, especially in Asia. Our local epidemiology data and experience might help globally. Take this data as an example. The top 10 most significant pathogen causing invasive disease. Globally, the majority occur in patients with immunocompromised status. We call opportunistic invasive mycosis, including Aspergillus, Candida, cryptomucor, and pneumocystis. The case number and the mortality rate is significant. In addition, we know in different geographic locations, there's blasto, cosi, histo, paracoccidiosis, and penicillosis. So we including this topic in our agenda. The impact of local epidemiology on global health is increasing because importation through travel, return immigrant, global trade, international medicine, as well as solid organ transplantation. Furthermore, when we're facing the patient might be return immigrant, might be international medicine, when they had some mycosis acquired from different geographic region, we physicians should be aware and inform your lab. Just because the biosafety concern, these three mycosis in specific selected condition, when passing the culture in hyphal condition, it not just biosafety level 2, should taking care in level 3 to protect lab medicine specialists. So this is important. The first example, a crosstalk between clinician and bench side. However, the challenge is the diagnosis. Why there's a limited evidence, limited epidemiology to support the importance, just because the limitation in diagnosis. Very important is the clinician at bedside, because what the mind doesn't know, the eye doesn't see, and the physician not aware the occurrence of invasive fungal disease will not do the following appropriate diagnosis approach. More complicated in current days is expanded spectrum of alternative fungal pathogen. This is invisible. What we know is a patient in critical ill multi-organ dysfunction status. Furthermore, there's a gap between the reality and what we anticipate in daily practice. FWG conduct a large-scale surveillance of the lab practice for diagnosis of fungal infection in 7 Asia countries. Many of you have great contribution for the data collection or study design. More important, we have changing host, we have global warming, we have now our target of the fungal pathogen or patient is a moving target. It's quite unique and different from those for solid tumor, for cardiovascular disease. Our target is moving regarding the host, regarding the fungal pathogen. So take an example, a recent publication from Clinical Infectious Disease. The author called for action. In 21st century, we are facing more and more agents targeting immune signaling pathway. They create more risk and a very unusual severe form of invasive fungal infection in patients treated with ibrutinib and other small molecule kinase inhibitor, and some activity seems off-target of tyrosine kinase inhibitor. So it is very important for medical mycology. The purpose or the benefit of better diagnosis is for individual patient as well as for the population, the society. For individual patient, through better diagnosis to guide appropriate therapy for this event, to plan the treatment strategy for their underlying disease. This is a key for the overall prognosis of this individual patient. Also, the diagnosis of this event will guide the secondary prophylaxis during the subsequent immunosuppressing status. We also, through a better diagnosis, to avoid unnecessary exposure to medication with some toxicity. More important, to prevent the delay in accurate diagnosis. Not necessarily fungus, might be bacteria, might be fungus, might be mycobacterium. This is very important in Asia. Of course, all this data accumulate to generate epidemiology data to improve knowledge of specific disease in specific patient population. Also, to establish diagnosis and measurement guideline is also the core element of antimicrobial stewardship to combating drug resistance. Also to persuade and guide healthcare policy, including health insurance coverage. Of course, without data, public awareness and the resource allocation are impossible. In addition to clinical practice, this diagnosis is also important element for outbreak investigation. No matter what antifungal strategy for our patient, diagnoses are important. Take an example. Many years ago, the guideline for empirical therapy already emphasized every effort should be made to determine whether invasive fungal disease exists before initiate empirical therapy, including biopsy, imaging, and others. Because the empirical decision to start is not as difficult as the decision to discontinue. And much of the evaluation at this time is to add in a decision about how to modify antimicrobial agent, when to stop later, or secondary prophylaxis in the future. Why timing is very important, and no matter which strategy. For example, nowadays we are more aggressive to use antifungal prophylaxis, including anti-mold agent in prophylaxis in selected patient population. We should be aware that this implementation will compromise the performance of very sensitive rapid diagnosis, no matter serum galactomannan antigen assay or PCR. So regardless of how well optimized a diagnostic test, the appropriate clinical sample taken and the stage of the infection is a key to the meaningful diagnostic result. If we take the sample to apply very sensitive test, turn out to be negative result, it's not necessary to exclude the diagnosis just because the yield rate have been compromised just prior exposure to anti-mold agent. So this is another key for better yield. We all familiar with a series of diagnosis approach. Start from localized. This is my wish list. Start from localize its presence and the significance through image as well as histopathology to demonstrate the invasiveness or just colonization or even contamination. We need to detect and identify to species complex level. Also, we are happy if we have data regarding the PK and the PD, including MIC, including TDM, or serum fungicidal activity. We hope we have biomarker to monitor host response and to predict prognosis. So this is a very complexity issue. We all familiar with all this conventional histopathology, immunology, and biochemical method, as well as molecular method. All these references are so wonderful. I strongly recommend you take time to read in detail. However, very, very important for better yield is from physician side. For different disease, it would be appropriate sampling strategy should based on syndrome. For example, this is a pulmonary disease. We should take the appropriate sample from the airway. For those with sepsis, we need to take the blood culture or blood sample for antigen assay, PCR, etc. So the second tier is sampling strategy should based on pathophysiology. For example, invasive pulmonary aspergillosis. From pathogenesis, we know it's inhaled through the research tract. So some you will be very feasible to take the respiratory sample, either exposure sputum or bronchoalveolar lavage. When the disease has been invaded in the tissue and causing damage in the sinus or lung, we may conduct fine needle aspiration or open biopsy. But when disseminated involve bloodstream, we can take the blood sample. But if the disease not involve hematogenous, you take the blood sample might be underestimate the occurrence of the disease. We all know histopathology is the golden standard. However, even this golden standard sometimes inadequate because several modes has hyphal form in tissue indistinguishable from those of aspergillosis. So sometimes pathology give the diagnosis of aspergillosis. You should be very open-minded to be aware we should in parallel send for culture because several fungi, they are look like similar, but these fungi, they are resistant to amphotericin B. In addition, the timing of sampling are also very important. Take this example. Some of the pictures are characteristic, typical, or pseudosporidium. However, treatment with echinocandin may yield such structure in Aspergillus species. In addition, sometimes you are very accept why I can see the hyphal in the histopathology, but culture was negative. Why? Take this example. We studied many years ago. More cases were identified through histopathology, but less from the culture. Why? Experts emphasize that the yield rate of mucormycosis isolation from tissue, just because mucor are particularly susceptible to chilling in the refrigerator. Also, they are damaged by our routine practice. Tissue homogenization will result in mucor fail to grow, even visible in the tissue. So this is very important. When clinicians aware suspect mucor, please contact and crosstalk to the lab part to modify the practice to increase the yield rate from tissue culture. Among all the traditional, conventional microbiology methods, they are very quick and cheap method is feasible in daily practice. This is from blood smear or the bone marrow aspirate. This is published data demonstrate the blood bone marrow aspirate demonstrate Penicillium malifii, Histoplasma, Candida glabrata, and the Candida albicans, as well as Candida tropicalis. This is provided by Dr. Shi from a cancer center in Taipei. This is incidental finding from a medical technician for hemogram. He said, Dr. Shi, would you please come here to take a look, something inside the cell. So this is a quick and cheap, but just because people are aware and recognize this finding. And the feedback to clinician will be guide the treatment. However, all this data also give a hint that all the yeast isolate from the blood equal to candidemia. Due to some clinical practice, we think this is a concern, so we conduct this study to emphasize non-Candida yeast isolated from blood or bone marrow, designed by FWG. The first author, Dr. Lin and the Dr. Lu, will share experience further. We conduct this study because we're facing that current guidelines recommend echinocandin as first-line therapy for candidemia, and the majority of clinicians thinks Fungemia equal to candidemia. But several non-Candida yeasts are non-susceptible to echinocandin, including crypto and others. In lab that are not equipped with rapid diagnosis tool, it often takes several days to identify yeast, and they may lead to inappropriate presumptive use of echinocandin in this patient. Even multi-top, it takes 1 to 3 days to conduct the test and to feedback the data. This data emphasized here, particularly for the blood culture collect in the outpatient setting as well as emergent service. The echinocandin non-susceptible yeasts are very common compared to those in hematology ward, ICU ward. So please be aware of this. Many years ago, we already aware that when we compare the patient with microbiology confirmed cryptococcosis in 2 time period, we already demonstrate that the more and more patients were diagnosed with positive blood or bone marrow culture. just because we have more and more patients with T-cell dysfunction. Why I repeatedly emphasize the importance of diagnosis, because no one size not fit all. Take this very familiar with the usual society pattern of fungal pathogen. Thus far, amphotericin remains the most broad-spectrum antifungal agent, including yeast and the mold. However, several of them are intrinsic resistant to amphotericin B. Fungal are safe, but they are narrow-spectrum, limited to yeast. ISHAM, Vori, POSA cover mold as well, but only posaconazole are active against mucormycosis at present time. Vori are very broad spectrum. They can cover several amphotericin-resistant mold pathogen. Regarding echinocandin, safe and become first line for invasive candidiasis, but these agents are relatively narrow spectrum, not active against cryptococcosis, for example. So, the importance of identification. Another reason for importance of the identification to species level of fungal pathogen are this example. We are talking about the emergent resistance in fungal pathogen 2 days later, but now we emphasize, and Dr. Lu among you shared the experience in Taiwan. Without identification, we are not recognize the occurrence of Candida auris in our patient. They were causing the spread and become a disaster in our patient. So, in daily practice, this is my wish list. And to demonstrate how important the crosstalk between bench side and bedside, we physicians should be aware of the risk, be alert when it occurs. And we are very happy if we can easy access to the test needed, because some tests are not available in the hospital you practice or not conduct every day. Of course, it's very important. The sample should be available and adequate for testing, because one sample might be need to send for bacterial isolation, send for fungal isolation, as well as mycology, but also for histopathology. So it is your how to make decision. In addition, it will be very happy if the lab can provide the data timely to guide us to make proper decision making. Of course, it should be all the tests should be affordable. In addition to what we emphasize, the test is sensitive or specific, accuracy. More important, all the data, all the results should be clinical relevant to guide us to management of this kind of patient. Because in daily practice, we physicians are confronting a very complexity situation. Facing a patient with fever or other presentation for fearless sepsis, we should distinguish sepsis from those systemic inflammatory response syndrome other than infection. But for sepsis patient, we should distinguish fungus from others. And for fungus, we distinguish Candida, or if the first line drug in your practice is azole, we should be aware of those azole non-susceptible fungal pathogen. If echinocandin is your primary agent and most common use agent, you should be aware, be alert of those non-susceptible fungal pathogen. Of course, for mold, you should be aware nowadays there's a azole non-susceptible mold. In addition, for selection of optimal antifungal agent for individual patient, we consider the host, the risk of specific pathogen, and the focus, because the PK/PD consideration. Also, we need to take consideration of drug-drug interaction for azo and others. In conclusion, diagnosis is a core element for select optimal agent, optimal dose to decide the escalation or the duration based on the focus, etiology, susceptibility, and the PK/PD. All this information with the help from our medical mycologist. Accumulate all this data, we can establish our local epidemiology to facilitate outbreak investigation, to facilitate the decision-making, policy-making, guideline development. All these are important, the diagnosis. So this is the reason why I include diagnosis as the first element of antimicrobial stewardship in Taiwan. All this information are essential for personalized or precision medicine in 21st century. Thank you for your attention.